Medication Administration, Part 4. This is Martha Olson from Iowa Lakes Community College. As we look at interactions, we know that citrus juices tend to interact with a lot of the statins or lipid-lowering and heart meds. So we want to do good education for all of our patients that take those type of meds as to avoiding any kind of grapefruit or other citrus juice. Birth control pills, they have a tendency to interfere with our B vitamins, so supplementing some of the B vitamins is appropriate. And antibiotics tend to make birth control pills non-effective, and so any woman taking birth control pills that's issued an antibiotic would need to use a secondary or a backup form of birth control during the period of time those antibiotics are taken. I've seen this a couple times with wisdom teeth getting removed, and the orthodontist doesn't do a good job of educating, the pharmacist doesn't do a good job of educating, and the nurse doesn't do a good job of educating, and all of those parts should have been talking to that young lady about a secondary form of birth control. Anticonvulsants speed up the destruction of vitamin D, and as you take that bullet a little further and think about the fact that vitamin D makes strong bones, people that take anticonvulsants for a long period of time have a higher rate of osteoporosis and osteopenia. And then your tetracyclines need to be taken with water because calcium or your milk products tend to bind it up and make tetracycline non-effective. Diuretics lower the potassium level in the body, that electrolyte that's very important for your heart and electrical activity. So as we look at the use of Lasix and Bumex as diuretics, we oftentimes will see potassium supplemented because with the loss of fluid from the diuretic goes potassium as well. Antacids decrease the absorption of phosphorus, so people that take a lot of over-the-counter Tums or antacids might see problems absorbing phosphorus from the diet. And then the blood pressure can be problematic for people that take alcohol and tranquilizers together, and those should never be taken together because of the possibility also of respiratory depression. A very large part of the nursing process for medication administration is the evaluation piece. I gave the med, I gave it safely, I did the 6 rights and the triple check, but now what was the outcome from that medication that was given? Did it lower the blood pressure? Did it change the vitals? Did it take care of the pain? Are they not nauseated now? So we have to think about what was the med given for, and did it have the effect that we wanted? As we look at the lifespan, we know that we have to think about, is this medication route and type appropriate for the person that is getting the medication? An infant can't obviously swallow pills, so you would either want to have a liquid form that you can put in a syringe and put into the buccal area, or a different type of medication, possibly topical or suppository for the infant. Their IM site typically used is the vastus lateralis because it's the biggest muscle that they have. We give injections in the newborn nursery, and so we use that vastus lateralis site right after birth. They cannot state their name and give correct patient identification, so we definitely have to go off of either parents or having good ID bands on that patient. Their pH in the stomach is very different than the adult, and so the absorption and metabolism of medications that are based off of breaking down with pH in the stomach can be affected. Vital signs are very different for the child and infant. Heart rate at birth is usually 140. We know that it goes down to 80 for the adult and down even lower for the older adult. So if you're giving medications like cardiac glycosides or digoxin, might really affect the heart rate, and we would not want to use the same parameters that we use for the adult. For the child, refusing medication is very realistic. You know, if you go up and ask them, do you want to take your medications, they are going to say no. So you need to present it to them in a positive way. As soon as you take your medications, would you like a red popsicle or a purple popsicle? Make it a positive, and not allowing them the chance to refuse the meds, because then, you know, you don't have many options. Their muscle mass is different when they start walking and toddling around, and so we'll have to think about what is the appropriate IM site. And then again, their vital signs, are heart rate and respiratory rate are typically higher than the adult, and their blood pressure is lower. For the older adult, we need to look at those lab values that relate with liver, such as AST and ALT. Your kidney function test is your creatinine clearance, BUN and creatinine. Look at those to think, how will the older adult be able to metabolize and excrete the medications that we're giving? Their ability to swallow is going to be important to assess before giving medications also. If they've had a stroke and they have dysphagia, we probably would want to assess a safer way so they don't aspirate. And polypharmacy with drug interactions is a consideration for the older adult that has many comorbid conditions causing them to take a lot of medications. This is an example of an old type of paper MAR. We don't use those much today, perhaps still in the long-term care setting, where you sign your signature on the paper form, just MO, and then on the signature page at the bottom it would be your full signature. When you sign into the computer, that is your electronic signature, and so when I go in and I scan the patient's bracelet, I scan the medication, and then I sign the medication off with the click at the bottom of the MAR. It's got my electronic signature on there because I am the one that is signed in. So it's important that we not let other people use our password or login on the computer, because it timestamps it like we did it. We want to look at those MARs carefully to make sure that we're getting the right route, right time before we give them. Our right route then, many different routes will be available to give medications. It will be important for you to look at your Potter and Perry book, to read the yellow pages and look very closely at the different routes. In this voiceover, I'm just going to be highlighting the different routes of medications that we use. We have to have the physician order the type of route that they want, and it must be appropriate for the patient. As we look at the different routes, we can see there are many ways we can give medications. The most typical is the oral because it's easy. We give a caplet, a capsule, or a tablet. We can also use liquid form. With liquid, make sure that you shake it well because it's sugar-based, and all the sugar, all the good stuff goes to the bottom just like Kool-Aid. So we want to make sure that we have that mixed well before we pour it into a liquid cup. As far as the lozenges, those are like cough drops, things that you would put into the mouth in the buccal area, and they would dissolve within that area. The GI tube is a very effective way to give a medication when the patient has problems from the mouth to the stomach. They've had a stroke and they have dysphagia and are aspirating. Perhaps they are having throat or esophageal cancer type of surgery. So we put a PEG tube in. It's a way to give medications right into the stomach. They're absorbed, and they get the acid environment in the stomach, and then they travel on to the small intestine just as normal GI function. With the PEG tube, remember to check patency before you put a med in, to flush with sterile water, 15 to 30 milliliters of sterile water before, and then each med is given separately. So if you have 4 meds, you're going to flush with water to check patency. You're going to give med number 1, then flush, then give med number 2, and then flush. The book talks about flushing with sterile water, and the reason that Potter and Perry has that, it's evidence-based practice that says when you have liquid medications, they can interact with tap water and the particles in tap water. Many of your facilities will be using tap water. It's part of their protocol, and so you might see a little bit different procedure being done within our facilities. On the test, you will answer sterile water. The mucous membrane, sublingual, buccal, swish and spit, or swish and swallow is a very effective way to get medication. Sublingual, I think of your nitroglycerin. We put it under the tongue. It's given for chest pain, and works very well because this sublingual part of the mouth is very vascular. The buccal area is into the side along the cheek, and it absorbs slower. And the swish and spit is typically a nystatin. It's for thrush in the mouth, and we want to give that last so that that medication coats that area and has a chance to maintain on that mucous membrane to work. So you would not want to give a swish and swallow or swish and spit and follow it with a glass of water. You want to leave it on there. With topical medications, make sure the skin is clean and healthy, and you've given the bath and washed it before you put these on. Many times these are very effective for your cancer patient, your end-stage patient that is not able to swallow, is somewhat unresponsive. We can give many medications that are made into an ointment or lotion in the thinner areas of the skin, such as the inner forearm, the back of the knee, and they absorb very quickly. Our transdermal patch, make sure that you label those. So before you put the patch on, you put the date and time, and then in your documentation you will be very clear as to where you put this topical medication or patch on the person, so that when we go to take it off, we're able to find it and take it off. Your parenteral, will be practicing these in the lab and in the classroom as well. These are your intramuscular, your subcutaneous, your intradermal. When we look at parenteral, we know there are many different sites and selections, needle sizes, things that we have to use a little bit of critical thinking with based on the patient and what's going on. So again, we will be practicing needle sizes, different types of landmarks, and use your yellow pages very well to study this so that you're prepared for the lab. As we give medications into the body cavities, we think of the vaginal area, the rectal area. We can give suppositories. Other body cavities are the eye and the ear, so we can do eye drops. We also have intraocular disc that can go into the eye. With these, make sure they are labeled appropriately. We would not want to use a medication that was intended for the ear into the eye. Obviously, we could cause a lot of problems. For the ear, make sure that you are looking at the age. If it's an adult, you pull the pinna up and back, administer the eardrop. If it's a child 3 or under, you pull the pinna down and back, and that's to pull or get that eustachian tube in a correct position to be able to utilize those eardrops. For the eye, remember you put it in the lower canthus. You want to have a tissue handy. Do not touch the medication dropper to the eye, and you do not drop it directly on the eyeball, but down into that lower mucous membrane. Hold pressure to the nose for a minute so that it does not go systemic after giving an eye drop. Our respiratory medications work very effectively. Handheld breathing treatments or acorn nebs, there's different names in the different facilities for those. The medication is inhaled over a period of 10 minutes with pressurized oxygen to help assist getting that medication to the lower airways. We always give a bronchodilator before we give the corticosteroid, because the bronchodilator kind of opens the airways to help that steroid to get in further to the respiratory or to the bronchial tree. As we look at the inhaler, you think of your asthmatic that has a little bit of problems breathing, and they use their inhaler either on a regular basis or as a rescue med to help give them a little bit of bronchodilation. Your respiratory meds need to do good oral care after they use them, or they will get a thrush in their mouth with that, and so good oral care is always indicated. For respiratory treatments, get a heart rate, listen to lung sounds, and get a blood pressure and pulse before administering the breathing treatment, and then you're going to listen to the lungs and get vital signs after as well, because many of those are sympathomimetic drugs and they will increase the heart rate, and you want to make sure that the patient tolerated them as well. There's a respiratory treatment we give to small children called racemic, and it gets that heart moving along pretty well, increasing that, and there are times we've had to shut the medication off because the heart rate has significantly increased during that breathing treatment. So we want to assess before and after to see baseline, and then afterwards to see did it help, what is our evaluation of that. Special considerations for our populations will be talked about in the next PowerPoint voiceover. We'll think about the pediatric, older adult, our pregnant woman, because you have both the fetus and the mother to consider for medications and the crossing of the medications into the fetus through the placenta, and then your patient that has difficulty swallowing, the dysphagia patient. So we will continue on and finish up this medication administration with part 5.